everyone. A very warm welcome to today's panel discussion hosted by ETHealthworld on the theme What It Really Takes to Be a Doctor Today. The journey of becoming a doctor in India is often described as one of the most challenging and noble pursuits. It begins with years of rigorous preparation for medical entrance exams, followed by demanding MBBS curriculum, internships, and often super specialization. For many, it means a decade or more of study, sacrifice, and financial strain. But even after the white coat is earned, the journey does not get easier. Indian doctors often face overwhelming pressures, patient loads, high education costs, and even infrastructure, and the daily test of balancing compassion and burnout risk. So, globally, doctors everywhere are navigating their own evolving realities. In the West, challenges include regulatory complexities, rising system costs, and the real issue of physician burnout. Clearly, while the landscape differs, the core question remains what does it really take to be a doctor today across geographies? So, today we have been joined by two distinguished voices with us to explore this subject in depth. I would like to welcome Dr. Shuchin Bajaj, founder and director of Ujala Cygnus Healthcare, and Dr. Kirti Singh, director, professor, and former head of ophthalmology at Maulana Azad Medical College, New Delhi. She will be joining us in some time. And I am Rashmi Mabian Kaur, principal correspondent with ET Health World and also the moderator for this session today. So, I would really like to start the conversation by touching upon the training and early years. So, Dr. Bajaj, as a leader in healthcare innovation and management, how do you see the role of doctors evolving beyond clinical care into areas like healthcare system and leadership and entrepreneurship?
Yeah, thank you very much, Rashmi, for having me. And, we are going through times that are changing faster than we ever thought with the advent of technology and the advent of newer career options. And I see a lot less interest amongst young children in the medical profession now. So I think it's a very good initiative that you've brought. And I hope a lot of young people see this and they don't see doctors in that traditional role of waking up in the middle of the night to go and see an emergency patient. That's not the only role that doctors play now, although that is a very important role. But I think the 21st century Indian doctor has to now wear three stethoscopes. One for the patient, which we've been used to seeing all our lives, but one for the system and one for the society as well. Clinicians are increasingly moving into health system leadership, operations, policy, because we all realize that the biggest gains have always come from fixing pathways, not just prescribing the pills, right? And we've outsourced the fixing of these systems and pathways to bureaucrats and politicians and businessmen for too long. And doctors do now know this, and evidence also shows from international health management research that hospitals and medical systems led by physicians tend to always score higher on quality rankings. And that's a signal that clinical judgment at the top table matters for patient outcomes and safety. Uh, on the parallel, we are also seeing a surge of clinician entrepreneurs building care delivery networks, diagnostics, health tech, like I've done all my life. And just we were discussing earlier also that expanding the MBBS seat capacity almost threefold from in the last 10 years. I think now this year we'll have more than 1.25 lakh MBBS seats. I think this is creating the largest pipeline of medical graduates in our history. And this is a leadership opportunity as much as a manpower metric. Also, on the ground, digital public goods are changing the canvas a doctor works on. So, for example, eSanjeevani, I think, has delivered more than 35, 36 crore teleconsultations since launch. ABDM has come in with this huge number, creating, I think, more than 60 crores or 70 crores ABHA IDs with around 40 crores linked health records. So doctors can increasingly coordinate care across distances and time, not just inside their four walls of the clinic that they used to. We saw a news in your news portal only recently where a doctor sitting in Gurgaon was operating on a patient in Hyderabad with the advent of this remote technology. And these things, I think, are putting clinicians and allowing them a much bigger canvas to paint on that has traditionally been possible. It has allowed clinicians to make an impact and difference across multiple geographies, across a much larger number of community members than was earlier possible. So I think we have to really think seriously about putting clinicians into operating roles like quality heads, CMOs, CEOs, and back them with strong managers, because sometimes they feel that they are not good enough just because they've not been trained in these things. But if they have good quality managers working with them, they can bring much better results.
Right.
Uh, Also, we really need to go into the early days and build leadership tracks during your MBBS and residency programs. So I strongly feel that teaching finance, HR, process designs, etc., should be an integral part of your MBBS and residency program. And maybe you should have some specific residencies also
Hmm.
for this, medical finance and medical processes, medical entrepreneurship, hospital management. These should be dedicated tracks in your MD programs. And
Okay.
I think we also need to use technology a lot more, use ABDM, use ABHA IDs a lot more to, build this continuum of care across families, across communities that doctors can utilize.
Hmm.
So I feel medicine today is not just diagnosing and treating illness in one individual. It is actually diagnosing and redesigning the entire system of care across much larger communities. And I think doctors are very well poised to do it now.
Okay, so you did touch upon medical curriculum as well. Now that we're talking about the patient burden as well, if we could really talk on the technology and telemedicine that are often described both as solutions and stressors. From your perspective, do you truly see this help or reduce doctors' workload, or do they introduce new complexities according to you?
I think both depends on whether the technology is completely inbuilt into the workflow or
Mhm.
is, as an addition. So most technology people that I meet have this, never ending and famous grouse that doctors are not accepting of our technology. They are very set in their ways. They don't accept technology. That is why it's not working. It's not true. I mean, I really find it very strange that people accuse doctors of not being accepting of technology when we've been using technology, I mean, forever, literally. Even our stethoscope is a piece of technology, right? We've
Yeah.
been using CT scans, ultrasounds, X-rays, MRIs ever since, even when your banking was all about paper ledgers and your, commerce was all literally commerce sitting across a shop. You had no e-commerce, nothing, no Excel sheets. We have been using technology for a long time. So doctors are smart people. I think they use technology very consciously, and they use it when it either saves them money or saves them time or gets them more patients. It's very clear to them. And I think it depends on if you can make it very in intuitive to use that technology,
Yeah.
and like a stethoscope, right? No doctor says that a stethoscope is a burden on me. I have to carry it all the time. Why should I use it? Do you hear
Yeah.
us saying that? We use it very intuitively because it works
Yeah.
well for us. But another side is that scale isn't same as simplicity, right? A stethoscope may be very simple, but doesn't lend itself to scale a lot. So,
Mhm.
like e-Sanjeevani, I said, huge scale, crores of teleconsultations, but I'm sure there are gaps in it. I'm sure there is quality screening tools, triaging quality, etc., which is working in it. Telemedicine hasn't really caught on because of that. So I think we really need to see technology as an assistant, as a nurse to the doctor and not the master. So we have to embed the checklist, embed the decision support, embed the closed loop referrals into the workflow, make it intuitive. And we really need to make sure that doctors are comfortable using it. It does not waste their time, does not, take more time to use technology. It actually saves time. And uh, sometimes people say, no, the doctor's touch is very important. If the doctor holds your hand and puts his hand on your shoulder and says you'll be okay, only then will the patient
Right.
be satisfied. You can never replace it. I
Yeah.
agree. I mean, I'm not saying, technology will replace the touch of the doctor. It's not tech versus touch.
Yeah.
It's tech that helps the touch. It protects the touch. It gives you a better quality diagnosis. It gives you better choices of treatment. It is standing there like the nurse that helps the doctor in getting the patient well, right? It's not replacing the doctor. So I really feel
Um,
that technology is the future. There's no getting away from it. Technology will never replace doctors, but definitely doctors who use technology will replace doctors that don't.
that I agree, sir. So, going on to the third question, with healthcare privatization, do you see these trends shaping young doctors' entry into the profession, both with their motivation and their ethical compass?
See, we carry this argument a lot. We hear this argument a lot that with privatization of education, doctors run after money. They have to justify the high cost of the education. But we feel that what I feel is, let's not look at the doctor when he's in the or she's in the private medical college, right? Look at the doctor when she is studying in eighth or ninth.
Yeah.
That is when they make the decision that we want to become doctors, right? Eighth or ninth class is the time when they really think about, let us study for medical. It's a very, very hard exam to crack, right? So this year also for the NEET exam, 25 lakh students appeared. So, and you have 1 lakh seats. So, and most of these, uh, only about 10,000 or 15,000 top rankers out of these 25 lakh will get into government colleges on a free seat. So it's not like they've decided in 10th class that, oh, I'll go to a private college and I'll earn money, right? They all want to top this exam. They study hard. They are studying when the children they are with are playing around. They're participating in extracurricular activities. They're going on school trips. They're attending weddings. They're all studying at that time. They start in the morning, study till late in night. So it's not really about money at that time, right? Not at all. They want to become doctors. That's why they are studying so hard. That's why trying to crack this exam. And in India, it's difficult to get into a government college. As I said, 25 lakh students appearing. Out of that, 20,000 getting into a government college. So it's less than 0.1%, right? So we can't blame them for ending up into private colleges because seats are not enough. Clearly not enough. We are increasing seats, but still they are not enough. Uh, Second, I think at the delivery end, the doctor patient ratio again doesn't look as bad as it really is because it's really skewed. The doctor patient ratio is balanced out because we have more than 10 doctors per 10,000 population in urban areas, but less than 2 in the rural areas, right? So they balance out as 7 or 8, but I think we have much more in urban areas and very, very few in rural areas. And also the out of pocket expenditure is going down now. Earlier it was very high, but it's going down, but still much higher than what it should be. So all these things, uh, I don't think the commercialization of training is really a big part of it. It is a part of it for sure, but it's more of human reactions. And I mean, we can't really commercialize trainings and then socialize the responsibilities. We have to finance the pipeline ethically, and then ethics will automatically flow back into the care. So we have to make sure that all these students that are going in, as I said, you have to have dedicated tracks for them. So patient ethics, responsibility, quality of care, all of these need to be built into the system. We are teaching the hard skills very well. Indian doctors are amongst the best in the world for sure. So the hard skills are there, the softer skills and the communication skills, the ethics, financing, all of these have to be built into the curriculum, and they will play a much greater role in ensuring that the younger doctors go down the path of the noble profession as we've envisioned them to be, rather than treating it just as another source of earning money, which is in fact a very difficult source to earn money.
Yeah.
I mean, if anybody really wants to earn money, I would never advise them to become a doctor. It's like a very hard path to earning money. You do earn money, but yeah, I mean, if you put in the same amount of effort into any other business, you would earn like minimum 10 times the amount of money that you would earn here.
Okay, so now that we've kind of gotten a very good picture of how things are moving in India, if we could kind of get from a policy and global health perspective, what are the challenges you think are faced by doctors in India as compared to those in other countries? If you could touch upon those aspects.
Yeah, so policy wise, I think one is that we do not incentivize doctors going to work in aspirational districts, rural areas, or smaller towns. It's exactly the same. Most other countries, you will see, even in US where it is fully commercial, you would see that if you want to practice in a smaller town or a rural area, you would get much more incentives and advantages compared to a person saying wanting to set a practice in New York or a big city. Here, we don't make any differentiations. If an MD in internal medicine wants to set up a clinic in New Delhi versus setting up a clinic in Kathal or Haldwani or Kashipur, exactly the same requirements, exactly the same Clinical Establishment Act, exactly the same responsibilities. For NABH accreditation, you have to achieve exactly the same things. So there is no advantage to going to a rural area, whether in terms of statutory obligations or financial obligations. You don't get any financial breaks. You don't get any income tax benefit. You are not charged, for at a separate slab. So these kinds of, I think, incentives we must really think of providing doctors who want to go and work with the rural communities. Second, I think it's only doctors who have to face this compulsory 1 year kind of a rural posting program or 2 year bond to work as in a rural area. There is this feeling that the government spends a lot on doctors training, and that is why they should work for a year or 2 years. It's really not very useful because the doctor who comes fresh out of MBBS, when they're going and working for a year in a rural area, all they're thinking about is how they can qualify for their next MD entrance exam, right? So they're not really very interested in working for the community there. Second, also, the amount of money being spent on the doctor's training. I think the doctors also work during that training. They take care of patients. They take the clinical rounds. They work with as interns. They work as residents. I think it's not just pure investment. The government is also getting to run a full medical college hospital along with that, based on these young doctors, right? We all know that the younger junior doctors do most of the work in a medical college hospital on a day-to-day basis. Of course, the professors and the consultants are there to ensure quality, to guide the right pathway, but the on-ground work is done mostly by junior residents. You've seen many times the day the junior residents go on strike, the hospital automatically almost shuts down, right? They say no OPDs can be done because junior residents are on strike. No surgeries are being done because they are on strike. So they handle quite a lot of workload at a very low pay. So I think the government has a balance in that compared to, say, for an engineering or an architectural college. government is subsidizing all those as well, right? Is the government asking the engineers to go and work in rural areas for 2 years, or the architects to work in rural areas for 2 years? In fact, when they are not doing anything during that 4 years in the college as well. So that is something that the government should look at. I'm not saying it should be taken away completely, but I think post your MD, there'll be much better resources to work in the community than just post MBBS. Third, I think we really need to incentivize the super specialists and the senior doctors to come and work with the government. So, if you see most government hospitals, except for the medical schools, do not have a steady supply of super specialists like cardiologists, neurosurgeons, cancer specialists, because the pay structure of a super specialist in a private versus a government institution is very skewed. So we need to see how we can incentivize these doctors, because see, everything is not about financials for the doctors, that is for sure. Doctors need one of the three things. Either they need a very good academic environment. That is the reason why you would see many senior doctors staying on at institutions like AIMS and Subjang for a very long time, CMC. You and I both know, if a professor at AIMS comes out, resigns from his job and comes out and joins a private hospital, any big private hospital would gladly pay them 10x of the salary that they're getting now, right? What is motivating them to be at AIMS for their life? That is the academic environment, the research they do, the papers they publish. So they need either that, or they need recognition, which also gets them there, and or they need financial. So one of the three things a doctor needs. So you need to attract the right kind of people to work in the government institutions. So finances is not the only thing. If you can provide a good academic environment, if you can provide them recognition, they'll be happy to work there. Unfortunately, in a civil hospital which does not have academic programs, you don't get any of the above, right? The salary is not good. There is no academic environment, no residents, no publications, no research happening, and there is no recognition in a small town if you're working in a small civil hospital, right? So why would a super specialist go there? You have to provide either of the three. So these kinds of policy, and they're not very difficult to do. So if you can have any of these policy tweaks, I think we'll be able to provide much better levels of care to all of these people.
Okay. So, when we are speaking about incentivizing our doctors, do you think the equivalent is being done in the Western countries? Are there, because what is the reason that the doctors are also looking at that option of moving abroad or, practicing there? Of course, the pay is much better. That is one of the major factors. But what are the other factors that actually pursues them to go do that?
Yeah, I think all three factors which attracts a doctor are there in the Western countries. As you said, financially, if you go to a Western country like the USA, the financial pay package will be much, much higher, and the amount of work that you need to do is much lesser, because the load of patients is much lesser there. And some of the treatment costs are like almost 100 times Indian prices. So, and average I think is at least 10 to 15 times. So the pay package is much higher than the research environment, if you choose to do so, is much easier to do. We've seen many of Indian scientists, Indian doctors going to the US and publishing a lot of papers, doing a lot of research, a lot of academic initiatives. So I think that is encouraged a lot there. And then of course, if you are in a Western country and do some work there, the amount of recognition and fame that you get is very disproportionate to what you would do in India. For example, we all know the famous case of the first fertility specialist out of West Bengal, who did the first test tube baby, was not recognized, but the recognition came to people who were working in the Western countries. So I think this field is being leveled out more now with increased digitization, increased technology, increased visibility of people across the globe. It's getting to be a much flatter place, but still takes some time. Financially, of course, it will take a much longer time to achieve parity. These are some of the things that are attracting the young doctors, but I personally feel that the quality of life you get in India, even at a much lower pay, especially in a small town where travel distances are very small, everyone knows you. You get to be as a doctor, you get to be the elite part of the top 1% of the town very quickly. So so that recognition, that kind of a life is very difficult to achieve in the Western countries. So a lot more doctors are choosing to come back, choosing to stay here than what it was when we were training. When we were training, I think it was the aspiration of everyone to, go to a Western country. My sister emigrated out very quickly, and she always used to, tell me you should come to the US as well. You should come to the US, and I was like, no, no, I need to work in India. There's a lot more need here. And she used to say, "Nahi, nahi, you are doing the wrong thing." Her favorite line was "Ulti Ganga baha rahe ho." People come from small towns to settle in Delhi. Then from Delhi they go to Western countries. You are in Delhi and you're going back to the small towns. That's the wrong way to go. You should emigrate out. So I was the odd one out at that time, but I now see many more people doing that. Many more people preferring to live in small towns because of the huge travel times, traffic congestion, pollution in the big cities, and also the quality of life that you get, the recognition that you get in a small town is much, much, much higher compared to living outside, far from your family, no social support. Uh, Not much support in the house. You need to do everything yourself. Here, at a much lower pay, also you can afford to, hire a lot of help around you, get a lot of things done, and the social support
Yes.
ensures that your work gets done much easier. So all these things I think are much better off in India. We are much better off, and the future, of course, belongs to India. The next 20, 30 years, I think, till 2047, I think are absolutely India's time. So it's a very good place to be in right now.
Okay. So, since you have been in this for a long time, how do you see the trust in doctors? Is it kind of improving? Do you see the doctor patient relationship getting better or going for the worse? If you could give me a little insight on that.
I think it's a little up and down. See
The
the
key
model.
differences that you see across geographies, especially between the doctor-patient relationship, and how does that affect doctor's role, his satisfaction, and the retention level in any hospital?
See, in India, still trust remains paternalistic, but is shifting towards partnership. Right in the
Hmm.
West, if you see, shared decision making is the norm. I mean, the doctors explain each and everything. They share the decision with the patient and the relatives. In India, it's still more of this is the thing you should do, and please sign here, and that's it, right? So, but it's a matter of time also, right? In India, the patient load is so much that on an average, I don't think we spend more than 3 to 5 minutes per patient. Whereas in the Western geographies, the doctor spends at least 20, 25 minutes, sometimes 30 minutes with the patient as well. So this also creates a little bit of stress and dissatisfaction that the patients always feel I was not given enough time. So I think one thing is we need to make sure that as the number of doctors are growing, we spend more time with the patient. We do a lot of shared decision making. We make sure that the information flows freely. We don't constrict the information within our ivory towers, which doctors are prone to do a lot. We feel that we've studied for 15 years, so we are much more qualified to make a decision for you, and you don't understand anything. That is not the truth. Now with technology, and it's becoming a much much more level playing field. Patients understand their disease, their bodies much better sometimes. So I think it's always better as doctors to reduce this imbalance of power that we have in the medical transaction, right? There is this huge black hole there of information that doctors say, no, no, you are having chest pain. Now you must immediately lie down and let me put a stent inside you. If you get up, you'll die. This kind of an information gap is there. The patient has no power in this transaction, right? What should the patient say now? I don't want to die. Okay, you put in a stent. But then this leads to a lot of resentment, because as a patient, I was not involved in this decision at all. I had no power in this transaction. Now, if something goes wrong, then I'll be, very angry about it, that, this was done without my consent, without my any power in this, and now this has gone wrong, so it is entirely your responsibility. So that is something that we really need to work on. We have to sit down with patients, their relatives, make sure that all decisions we make are shared decisions. Patients get as much information as possible in this decision. Unfortunately, without technology, that will not be possible in the Indian scenario. You, as a senior person working in healthcare, you've seen as much of hospitals as any of us have, right? You've seen the load that a government doctor has to face. They are seeing like 200 patients in an OPD in 6 hours. So, I mean, if they spend 20 minutes with every patient, they won't be able to see even, one-fourth of those patients. And then where will the other three-fourths go? So, technology has to play a much bigger role in this, and we really need to ensure that patients are educated well, they have better health seeking behavior, they make the right choices in partnership with the doctors. I mean, just leaving the patient to make the choices sometimes can have disastrous consequences as well, because they start making the wrong choices. They trust the social media and they feel that these are the things that we should do, which is, I mean, it's sometimes to horrifying effects, right? We've had like very, very educated, very powerful people making the wrong choices. Um, I don't know if you've heard of the case of Steve Jobs. He refused to take any allopathic treatment for his pancreatic cancer. And in hindsight, you see, it was not the right choice, right? If maybe we could have done something different, but if we make shared decisions, I think we can nudge the patient towards making the right choices. Of course, even then, some will make the wrong choice, but at least it won't be a feeling of angst in the patient that I was not, involved in the decision making. At least I made my own choice. I saw the rights and wrongs, the pros and cons of each and every decision, and then I had the power to make that decision. That is in itself a very empowering thought, a thought that, makes you happy. And we all know the power of the placebo. If something makes you happy, the chances of success of that treatment are much higher than if, a treatment is making you anxious or sad. Then the chances of success of that treatment go lower. So I think all these things we need to work on a lot more compared to what it is already in the West. But we are getting there much faster now with the help of technology than we could have done it, say, 20 years earlier. Okay, thank you. Thank you, Dr. Shuchin. So, coming back to you, Dr. Shuchin, what role do you think health policies will play in alleviating or, exacerbating issues like burnout or access to care and the cost of medical education, which is kind of growing day by day? So I was just talking about the medical education as well as the policies. So as I said earlier, you can't expect to commercialize the training and the education and then socialize the outcomes out of it. It is something that's deeply ingrained and tied in. And if we can use technology a lot more, we'll find better solutions. Policy wise, I think we've spoken a lot about the rural health postings, the compulsory bonds, and the financial and statutory implications, as well as incentives that we can offer to the younger doctors to ensure that we have a more even spread of medical talent across the country, rather than, having 75% of our doctors treating only 20% of our population in the eight big cities that we speak of, where the doctor ratio is more than double of the WHO recommended ratios, whereas the rural India and the small towns make do with just two or three doctors per 10,000 population. So both financial as well as legal as well as statutory incentives need to be given, and the training program also needs to be tweaked a lot more to having dedicated tracks to, as I said, finance, ethics, compassion, hospital management. All these tracks, if we can start building in, we'll get a much more evolved medical workforce and a much more workforce which is ready to work with the communities than just focusing on the financial aspect.
Agreed. So, coming back to you, Dr. Kirti, we really wanted to kind of get your input on uh, how do you think the MBBS curriculum in India has evolved, and is it keeping pace with the real world practice demands today?
So, thank you for having me here. I was operating, so I got late, and then there were some glitches in joining. Technology has to be also at the till the end. Have your question whether MBBS curriculum has evolved? It definitely has. It has evolved leaps and bounds. Whether it has evolved in sync with the reality, yes, it has. But whose reality? There are two realities we're looking at. One is the reality of the student who wants to become an MBBS doctor and then wants to specialize. And the second reality is the patient who is waiting for that MBBS doctor to treat him or her. So there are two realities. And the third, obviously, is social reality, societal reality, which comes in between both of them. But let's talk about the two realities. So for the first one, our society, India, and even abroad, has devalued MBBS. There is no value of MBBS. You just do an MBBS, you will not get a job worth 60,000 in Delhi alone. Okay. So naturally, nobody wants to just remain a plain MBBS. They want to do a specialization. For specialization, they have to clear the NEET exam, the PG entrance exam. The seats are few, the aspirants are many. And unfortunately, because of the social affirmative action of our governments, the seats per se for the categories are less, much less. So there's a constant pressure in these children the moment they join MBBS that they have to clear the NEET exam. So their curriculum, which was designed for having a comprehensive uh, education of the entire medical system of the human body, the focus becomes more on the good to know, the rare cases, because these extra 2 or 3 marks will determine their future realities. Okay, so their focus on the must know areas is much less, and their focus on good to know areas is much high. Keeping the other realities, the patient's reality, patient wants to be treated for their ailment. So their ailments are same. Human body hasn't changed in 2000 years or to 1 million years. It's not going to change overnight. But yes, the diseases have changed. You have much more metabolic diseases. You have lifestyle diseases. So the patient reality is that they want the doctor to treat these diseases. However, having said that, Dr. Suchit also was saying the same thing. The patient very often thinks that just by reading WhatsApp, reading newspaper, or looking at some news articles or media coverage, they become doctors in themselves. They want to, their reality is that this is my disease and this is my diagnosis, this is my treatment, this is what my aunt said, this is what my uncle had, this is what my father had, and this is what the people say. So treat me according to this. Now, that's not possible. So the realities somewhere are blurring. I'm very glad you asked this question because kiski reality? Disease, human body, तो वही हिंदी is okay with you in between?
Yeah.
तो ह्यूमन बॉडी तो वही है जो पहले थी, बदली तो नहीं है. अब ऐसे कैसे इलाज have become more complex because the understanding of human disease has become much more. COVID was a glaring example. We had no clue what COVID was all about. That is why we had we all fumbled and we all died. So many doctors died, so many staff died, so many patients died because we did not know what virus we were dealing with. Same virus, flu virus had come around. Now we don't even think about flu anymore because we have understood the disease. We have taken measures. For COVID, we did not take we could not because we didn't understand the disease. So understanding the disease has evolved. Therefore, treatment has become more complex. The problem with the complexity of treatment is that the lifespan has increased, morbidity has gone down, but the cost of treatment has increased. But the mindset of the patient has not changed. So reality that way is that इलाज मेरा सब अच्छा होना चाहिए, पर मेरा सस्ता होना चाहिए. Because I am a poor person, but I need the best treatment. So that reality we need to synchronize from the patient side and the reality from the doctor side, who realizes that 5.5 years of grueling practice in MBBS, doing all the curriculum, anatomy, physiology, biochemistry, pathology, medicine, surgery, everything, will not give him a seat in the NEET exam unless he prepares different.
Okay, so those were very hard-hitting points that you addressed, but very to the point. Going to the next question, having mentored generations of doctors in government hospital, is the high patient load more of a training opportunity or a burnout risk for young doctors today?
See,
Dr. Gul.
I have done all my training from government hospitals, right from MBBS to PG to becoming a faculty. I've been working now for almost 35 years. So my view is only of a government hospital because I haven't faced the private side. They have their own problems. It's not that they are very happy there either. The problem with us in a government setup, especially in a national capital of Delhi, where everything is free. Now, free things are good, but with the freedom of things becoming free, the patient also has to have a little bit of responsibility. Moment you give things totally free, it is taken for granted. So the expert doctors are there, the expertise is there, everything is there, but the medicines or the equipment, because it's a government hospital, because government has its cost to cover, they have economical restraints. The as per government norms, it has to be the L1 in market, lowest tender system, L1. That is a very good safeguard inbuilt to prevent overpricing. But because of that L1 thing, both the medicine and the equipment may be different. Now, having said that, student is or the doctor is providing to more than 200 patients per OPD. I was operating today. We have more than 89 patients in one OT operating. Okay, we are many of us operating, not only single person, but you are supervising the residents also. You're teaching along with operating. So your load is so-called X, but the actual implication is X plus 3 because you're supervising teaching because it's a medical college and you are working within your restraints because all the complex surgeries, you do not have the complex equipment available and the patient refuses to buy it, which is fine because they can't afford it. In that situation, Ayushman may help because it will bring all the equipment in. So coming back to your question, in my having mentored over 3 decades now, I definitely find that the children who come in are already burnt out. Not burnout, they're already burnt out because they have studied so hard to clear the MBBS exam. I mean, you've heard of quota factories, you've heard of so many other things. These children have slogged for at least 3-4 years to become a doctor. 5.5 साल के बाद इंटर्नशिप खत्म करी, फिर से पीजी एग्जाम दो. अब आपका 1 साल का बॉन्ड आ गया है. बॉन्ड के बाद एग्जाम दो. फिर आप पीजी के बाद फिर से आप फेलोशिप के लिए एग्जाम दो. फिर आप टीचिंग जॉब के लिए एग्जाम दो या स्पेशलिस्ट जॉब के लिए एग्जाम दो. Everywhere there are multiple exams. So their burnout is inevitable. I don't know if you know the statistics. Many big, very big schools have stopped biology classes because not many people want to become doctors anymore. They realize that 10-15 साल कहीं नहीं गए आपके ट्रेनिंग के, minimum 10-15 साल, and when they see their peers who are having a more quality life, not only good gadi or good wife or good house, quality of life, you are constantly stressed. And because of the medical legal cases, because of the patient mistrust, and this mistrust is absolutely two-way relationship. It is partly that the doctor, in the zeal to do more, order more tests, and tests come at a cost. On the other hand, patients expect quick results. Like, why are most, if you see in the government hospital, in my hospital, every 1 week or so, some patient will beat up a doctor. It was unheard of in our times. We were not better when we were residents. Now our residents are better. Why? They beat them because they expect miracles. I mean, nobody can assure you of life. We are trying our best. So that high workload, seeing too many patients, and expectations unrealistic by the patients. Third, they see no future unless they keep working, even when they are 35, 40 years old. Now, for girls, you are a girl, I'm a girl. Let's talk about ourselves. You have a biological clock ticking all the time. Many of my students in ophthalmology, I'm an ophthalmologist, many of them are girls because it's a very good surgical field which girls excel in. They really excel in. We have very good fine skills, and it's a beautiful field. Now they are 35 by the time they even think of marriage. It's not easy for them because they are not settled. If they are not settled, if they have a child, how would they support the child? So, the again, realistically, if you look at the doctor's life, it's not at all easy. Patient's life, of course, is not easy. Patients they have disease, they are suffering. That is why they are patients. But training has to be, if my voice is reaching anyone, we need to restructure our training very much. We need to restructure. It is not realistic, it is not human to ask the doctors who at one time were the cream of India to keep struggling just to cover their heads with a roof and to even think of a quality life.
Okay, so the third question that we want to touch upon is really with the growing corporatization of healthcare and privatization of medical education.
Would you please be a little louder, Mr. Ashmi?
Yeah, is this better?
Yes, much.
So I'm coming to the third part of the question because we're almost running out of time. With the growing corporatization and in healthcare and privatization of medical education, how do you see these trends impacting the ethics, accessibility, and motivation of young doctors today?
Let me give you a very simple example. Thank you for asking that question. How many government colleges are there in India and how many private? The ratio is almost 4 to 5 times private, minimal. Compare that to, let's say, a Western country. There they have no government hospitals. They only have private. So their children know that they have to take loans for medical education. They keep paying back loans. It is entrenched in their minds. Whereas for us in India, India is a country which is developing. Doctors have always been a noble profession. For that noble profession, government had subsidized the costs. I was a beneficiary. I studied in Lady Harding and the names at a very minimal cost. And my parents were refugees from undivided Pakistan. They could not have afforded my study in a private college. They couldn't have. And because of this government subsidy, I could become what I did. So I'm very thankful to our government. Having said that, government is gradually, because of whatever reasons, withdrawing from healthcare. The budget spent on healthcare is abysmal compared to the developing countries. So privatization has crept in, very much so. Now, if an MBBS student, a parent has to shell out, let's say, 40-50 lakhs for a child to become MBBS, and then the same child to get PG, let's say in orthopedics or ophthalmology or any surgical branch, again 1 crore. So the investment of the parents is 1.5 to 1.7 to maybe 2 crores. The parents have wiped out their savings on educating one child in a private college. Where is nobility in this now? And there's no option for this MBBS student to earn and pay back the loans because of the sheer population of our country. In Western, it is not so much population. They can work in libraries, they can work small part-time jobs and pay back the loans. That cannot happen. Once you are a doctor, अरे doctor करके आप burger बेच रहे हो, the social society will kill you. So that has not changed. But the nobility, and I want to ask one question, why is nobility only the domain of doctors? Why can't the educationists be noble? Why can't they provide free education to doctors? Why should they take 40 lakhs for an admission to an MBBS? They have 200 students, 200 by 40 lakhs multiply. Don't need that much, do you? Okay, why can't an architect be noble? Why can't lawyer be noble? Why is only doctor being noble? Because he's handling diseased minds and bodies, but they're diseased individuals in the society which need to be handled too. Let's say a legal. Have you ever heard of a lawyer going free pro bono? Very few. But doctor is supposed to go free. So that corporatization of the hospital, when you walk in, you expect a VIP culture, you expect hospitality. We are hospitals. We are not hospitality business. We are not here as an hospitality person. We are here in the hospital to heal. And healing, make it very without frills. If you make it without frills, without fanfare, it is very much feasible, cost effective. But if you have frills, you want round the clock AC, you want cleaning, you want constant things, and you want all the equipments at the best price and the best equipment. That's not realistic. So I think somewhere we have lost our realism कि हमें चाहिए क्या? हमें इलाज चाहिए कि हमें बहुत बढ़िया जगह पे इलाज चाहिए. हमें इलाज चाहिए. So when we need इलाज, corporates are actually not delivering just ilaj. They are delivering a culture of hospitality along with hospital care. Therefore, it comes at a cost. Do you know how much a doctor actually earns from a patient in the ICU? Not even 1%. Let's say the bill is 1 lakh per day. The doctor will get 2,000 rupees a day or even less. काम सारा उनका होगा, but the structure, the team is important and the cost of ventilator or whatever. So if with that 1 to 2% of what you get, in case the patient dies, which is very possible, क्या होता है? डॉक्टर ने मरीज को मार दिया. The media, papers, everything, doctor ने मरीज को मार दिया. I wish we make the team accountable. It's not only doctors, it is nurses, it is OT technicians, it is even the clerks who are sitting and typing. One typo will cause problems. So accountability somewhere, we are a pyramid. We are a pyramid where doctors are at the top and we have become top heavy ki sab kuch inka, just cut them off, just target them. Therefore, they do not wish to do all this anymore. Doctors do not wish to perform all this because Dr. Shuchin also said, doctoring is not a profession to become rich in. You don't become rich as a doctor. You would earn 7 times more with the same intellect in a different profession. So they had not come in to become rich. They had come in to heal. But when they see this corporate culture, when they see this privatization, when they can't afford even their basic education, when their parents have to shell out money, that culture is very much eroded. So I don't think that noble thing should be given. Either everybody is noble. Why is only a soldier noble? Because he gives his life. Why aren't generals noble? Because they sit in the chair and dictate. Because they are also important. Without a general, you can't have a soldier. So So the whole structure, this nobility concept has to be rethought of. And moment you bring in privatization and corporate culture into medicine, you are actually devaluing all that dreams and nobility which the child who became a doctor came in with.
Okay. So, binding up with the last question with both of your responses briefly, Dr. Shuchin, if we look at the future, what will it truly take to keep doctors motivated, resilient, and fulfilled in their profession going forward?
Yeah, thank you very much, and very happy to hear Dr. Kirti's voice on these issues. Like her, my parents were also refugees from Pakistan, and I remember my annual fees for the medical college was 415 rupees a year. So those were very different times. Of course, if it would have even been 40,000, I wouldn't have become a doctor. My parents would
Yes, agreed.
did that. But now you have 40 lakhs also, and still those seats are being filled. So speaks a lot about what people think of medicine as a profession, and the rising income levels. So it's not as if those seats are going vacant. But of course, the intentions for becoming a doctor, as Dr. Kirti also said, if you want to really become rich, a lot of other industries where you can put your mind and body to use to earn a lot more. I think what satisfies doctors in the future, what it will take is, as I said, a lot of technology support, a lot of advocacy for their rights, a lot of government support in terms of financial, social, and statutory incentives, and a lot more hand holding from our own teachers as well. Dr. Kirti would be able to speak much more about it, but what we've seen in medical colleges also, sometimes the teachers also do not, recognize. As ma'am said, the children are actually already coming burnt out. They've been studying for this medical entrance exam from sixth standard in school. They've been, studying every Saturday, Sunday. They've not had any vacations. And when they come in, they feel that, oh, now we've realized a dream, but suddenly within a year they say, no, this is just the start. For next 15 years we'll have to study more like this. So sometimes the teachers have to handhold them much more. They have to be cognizant of their issues. And because in our times we've seen, when I was training in my MD days, we used to have like 80 to 100 patients in the ward with one resident. I was only there, and I wouldn't get to go to my hostel room for maybe 6 7 days at a stretch. I would be in the ward throughout. So those kinds of, I think, issues are the ones that burn the kids out, and we, as teachers, as seniors in the profession, we also have to realize that these are some of the things that we need to take care of, and it's not just the government and the policy decisions that will make a difference.
Dr. Kirti, your views on the same question.
So to make the children motivated, we need, like, what drives you? Just it's as simple as that. What motivates you? Money motivates, power motivates, respect motivates, comfort motivates. If I know कि मेरे को इतना पैसा मिल जाएगा, मेरे को इज्जत मिल जाएगी, मेरे को एक कंफर्टेबल घर मिल जाएगा, मेरे को आराम की जिंदगी, काम करेंगे, हार्ड वर्किंग सारे हैं. All doctors are hard working, but इट इज प्रोपोर्शनेट. अगर मैंने इतना काम किया तो मेरे को इतना तो कंफर्ट मिले ना. अगर मैंने इतना काम किया और मेरे को कंफर्ट मिला ही नहीं तो मोटिवेशन नहीं होगी. सो द पे स्ट्रक्चर, देयर हैज टू बी सम पे पैरिटी विद द अमाउंट ऑफ क्वालिफिकेशन. एमबीबीएस का स्केल बढ़ाइए इन सेटअप, not only in a government setup, everywhere. Like MBBS student will get 50,000 only for working the whole month. 50 आपका जो डाटा एंट्री ऑपरेटर है वो 25,000 कमा लेगा एक महीने में. तो आपने क्या वैल्यू रखी? डाटा एंट्री ऑपरेटर with 2 years of computer skills, 25,000. A child who has studied for 5.5 years, after getting that entrance level, will get 50,000. So obviously it is not commensurate. So we need to make the pay structure value दीजिए. मैंने पहले भी कहा है, I think you have published that. Do not shower rose petals on us when through helicopters. Give us value for our competence. We are competent, we are working hard, we will continue to work hard. but we need some recognition. So recognition for motivation, give pay parity. Second, do not take away our respect. Don't start blaming us for anybody's death. मौत इंसान के हाथ में होती ही नहीं है. मौत लिखी हुई है. अगर आप स्पिरिचुअल मानते हो, आप you study Vedas or Gita or Guru Granth Sahib, death is destined. You can only reduce the quantum of suffering. That's all as doctors we can do. Doctors भगवान नहीं है, वो खाली इंसान है, पर उनको इंसान का दर्जा दीजिए. Give that power, give that respect back. Power equation, as doctors also, they have to understand that power equation has changed, which is very much obvious that patients are more demanding. They understand things more because of the media and the availability of information at a click of a finger. So they understand more. So let us be more realistic of what the patients are. And last, industry, the role of industry. In a surgical practice, industry has a big role. So industry का role हमें कम करना पड़ेगा because very often industry calls the tune. So money at different levels has to reduce. Only then the doctors will be motivated to continue. अगर एंट्री पे भी पैसा देना है, मशीन खरीदने पे भी पैसा देना है और मरीज ने पैसा वापस नहीं करना, अगर पैसा मरीज से मांगेंगे तो कहेंगे डॉक्टर पैसा लेता है. That equation has to go away. So it has to be more realistic rates along with the industry curbing. Not only, I'll give you a small example. बहुत पहले आपके जमाने में भी होता होगा, डॉक्टर सुचिन के जमाने में तो डेफिनेटली होता था कि पहले कैंप्स होते थे, आई कैंप्स. ठीक है, lot of patients were treated at an eye camp, easy, affordable. There was one infection, I will not name it, you can look it up. Infection was because the ringer lactate bottle was contaminated. So fault किसका था? The person who had supplied it. एक संस्था थी जिन्होंने 100 के 100 परचेज करी, डॉक्टर को बोला आप ऑपरेशन करो. उस बंदे ने दिन रात लगा के ऑपरेशन की. उसने पहले भी करते थे वो ऑपरेशन, बट बिकॉज ऑफ दैट 5 एंड ऑफ दैट डॉक्टर्स कैरियर वाज क्रूसिफाइड कि डॉक्टर के हाथ में मौत है, इसने तो आंख में अंधापन कर दिया. हु वाज इट कल्प्रिट? द क्वालिटी कंट्रोल ऑफ द रिंगर लैक्टेट बॉटल which neither the संस्था check, because उनको तो हार मोती पहनाने थे, हार पहना के जिन्होंने बहुत अच्छा काम किया. So the accountability has to change. If you ask me one thing, accountability, जो accountable है उसी पे दीजिए. हर चीज डॉक्टर नहीं करता है. Nursing care, COVID deaths were maximal because of lack of nursing care, not because of lack of medicines. Doctors would take rounds, nurses would not come. Okay, so I'm not saying अच्छी nurses भी होती हैं, अच्छे doctors भी होते हैं, अच्छे technicians भी होते हैं, बुरे भी होते हैं. But accountability is not only for doctors. So to conclude, for motivation, make pay parity, reduce the discrepancy between competence and the pay given, give the respect back. Don't just start, castigating doctors for a fault which is not there. And third, most important, accountability, make it the team's accountability. The insurance given by a doctor to prevent this is huge. The insurance given by a technician is very minimal because उनकी पे कम है. बट टीम पूरी, लेट्स से कॉर्पोरेट हॉस्पिटल तो है ना उनकी इंश्योरेंस, वो नहीं कराते इंश्योरेंस, डॉक्टर्स को बोलते हैं कराने. सो देयरफॉर एट मोमेंट यू मेक इट मेडिको लीगल, वी शुड आल्सो रियलाइज दैट वी मस्ट हैव अ स्टैंडर्ड प्रोटोकॉल्स एंड मेक इट वाइड स्प्रेड कि ये चीजें फॉलो हुई है तो डॉक्टर इज नॉट अकाउंटेबल. दैट you people can do by entrenching with the health professionals कि these protocols are standard. If they are followed, then the doctor cannot be held accountable because we cannot give death or life. We can just reduce misery.
Thank you. Thank you so much, Dr. Kirti and Dr. Shuchin, for those candid and very deep, insightful perspectives. I wish we could continue, but due to time constraints, we would have to close it here. What we've heard today reflects while the medical profession is universally respected, it is also equally strained. In India, the story is about resilience amidst resource constraints, In the West, it is the sustainability in the face of systemic costs and regulations. But across geographies, one thing remains constant is the doctor's role is not just about treating diseases but also about navigating evolving healthcare ecosystem and balancing science with empathy and leading with both resilience and vision. On behalf of ET Health World, I would like to thank our panelists again and our audience for joining us today. Thank you so much and signing off.